right, so today we're going to talk about hyperactive muscles. Is it spasticity and or dystonia? And the objective that we should walk away with is to understand the causes and the effects of dystonia and spasticity, to be able to perform a physical exam to determine if it's dystonia or spasticity, and how do we treat them. What is this? This is the patient here. She may have been coming. No. All right. So this is a 25-year-old woman who was in a motor vehicle accident in December 23rd, 2015, and almost immediately afterwards, her head was flexed, the neck was flexed, and the chin was touching the chest. She could not move. And when I positioned her sitting, whoa, sorry about that. So here she is sitting, looking at the front view. Let's look at the side, the chin's touching the chest. I had her lie down on the table. Her mother has one hand on her head and the other hand here to try to get to stretch the sternocleidomastoid muscles. Look how tight they are. What would you do? So I put a needle in.
She just walked in.
You. Okay. So I put a needle into the muscle and injected the muscle. And you can see where the needle went. And here she is post-injection. And I didn't put the video up because I wasn't sure if the patient, I needed the patient's approval because we have not been able to black out the eyes. But we have the patient live and ready to do a little dance. Thank you very much. You want to say anything? All right. So really, it's important. Patients who have cervical dystonia, on average, it takes 5 years before they're diagnosed and 2 years before they're treated. And even then, it's questionable if they're adequately treated. So my view is that anybody who has abnormal neck positioning, we won't know if this is a dystonia or a muscle strain until they're adequately evaluated. And that includes putting a needle into the muscle, and in this patient's case, I injected some bupivacaine, it relaxed the muscle, she went home, I said, call me if there's a problem. Next day, called, she came back, and I did a phenol injection. Phenol is like alcohol. Alcohol destroys protein, so it destroyed part of the spinal accessory nerve that's right innervating the sternocleidomastoid muscle, and with that, dramatic improvement. What does this patient have? This is Dr. Stur's patient who had bilateral pontine strokes. And the pons is the location for cranial nerves 5 and 7. In fact, all cranial nerves with a V are located in the pons. So, this patient, bilateral pontine and cerebellar infarcts, could not open the right side of his mouth. So what is the problem? I put an EMG needle into the masseter muscle. There are 3 muscles that close the jaw on each side. The masseter is the largest, and we put a needle into the masseter muscle here, and that muscle was just firing away, non-stop. And that explains why he could not open his mouth. And then I asked him to open the mouth, and it's firing just about the same. I can't say that it's any more, maybe a little bit here, but by and large, firing away. Injected some bupivacaine, and you're going to see the results. But what is this, and why do we say it's a dystonia? Well, it's an abnormal movement for the jaw-closing muscle, and it's cranial nerve 5 innervated. With a stroke, the masseter muscles, if they were affected by the stroke, they should be weak, just as the cranial nerve 7 is, which gave him a decrease in the tone for the nasolabial fold, but on the other side, you can see the tone is intact. So I'm calling this a cranial nerve 5 dystonia with excess activity for the jaw-closing muscles, but cranial nerve 7 was affected, causing weakness. So let's put the needle in and inject some bupivacaine. Here he is, pre-injection and post-injection. And with the bupivacaine, this lasted, about a week, and then he was sent back to the acute care hospital, and we've not seen him since then. This is another dystonia. This is a woman who could not open her mouth for about 4 years, despite treatments with injections with a botulinum toxin. So here she is when she came to me on this date. She had been injected with one of the toxins, 150 units, then 200, then 300. That should be more than adequate to enable her to open the mouth. However, it did not, and the reason is the doctor who injected her only injected the masseter. Remember, there are 3 jaw-closing muscles on each side needed to be injected in the temporalis, masseter, and medial pterygoid, but only injected in the masseter, and that's why it didn't work. So I put a needle into the masseter, and look at the activity. Instead of continuous activity, she had bursts of activity, rest, bursts with a pause, bursts, and this went on not only for the masseter bilaterally, but also the medial pterygoid, which is located right under another jaw-closing muscle. Since the toxins are not FDA approved and insurance would not pay for this treatment, I injected phenol. So here she is pre-injected and post-injection. Now the mouth is open. Look at the hygiene of the teeth. And I see her about every 10 months for repeat injections. So this is an oromandibular dystonia. We don't see that very often, but for somebody who can't open the mouth or can't close the mouth, think about weakness or oromandibular dystonia.
What caused that dystonia? An accident?
So idiopathic, don't know in her case, but for cervical dystonia, 1 of every 10 patients has associated trauma. So the patient we just saw, car accident. I have another patient who is an auto mechanic and a transmission fell on his head and neck. Another one who is a gymnastics coach, and the student was doing flips and hit her in the head. So then I have a couple more. So 1 of every 10 cases with cervical dystonia is associated with trauma. Now, so we see hyperactivity for dystonia, and we see the EMG pattern can be continuous or it could be bursts of activity. How does that differ from spasticity? What is it that these patients have in common? The answer is spasticity. This one had a stroke. This one has Lyme's disease, picked up in the CSF, stroke, traumatic brain injury. So what's unique about this is that the corticospinal tracts are not intact because of the brain or spinal cord injury, but the anterior horn cell in the spinal cord is intact. And if we put the needle into a muscle, as for this patient here, you see that at rest, there's very little activity. or with mild stretching. But as you speed up the velocity of the stretch, then you get more EMG activity. So this is classic for spasticity. It's velocity dependent. Stretch the muscle slowly, you see a slow increase in electrical activity. Stretch it fast, you see more electrical activity. Clinically, what happens? You stretch it slow, you can get a good range of motion, maybe, if there's not a contraction. You stretch it fast, you're going to be severely limited. So I always say stretch it slow, especially to check range of motion, but also to prevent injury. And spasticity causes a muscle to shorten, to flex a joint, and lengthen to extend a joint. It's associated with EMG activity that diminished? No, so it's neither. Here's this woman. This is a typical pattern for spasticity in the upper extremities. Flexed elbow, flexed wrist. What's different about her? Fingers are extended. Normally, they're also flexed. And we use the modified Ashworth scale or an Ashworth scale to identify the spasticity. It goes from 0, no resistance, to 4. So I always think of 1, 2, 3, mild, moderate, severe. So we should be using the Ashworth scale when we're quantifying spasticity for our patients. And I'll give you some examples of where this could be used. So for this patient here, we see the brachioradialis and the elbow flexors. At this point, could I stretch her more? The answer is yes, and I stretched her out here, at which angle? Probably about minus 30, minus 40 degrees extension. She has a contracture. That's Ashworth 4. But the resistance I'm encountering up until then was probably about Ashworth 3. So think in terms of some way of quantifying and document where there's a contraction. Why should we even be treating the spasticity? Here's a classic example. Look at the blisters. So it's for skin care. Here's an example of a patient, stroke, walked around like this. What do we call this? An ulnar inhibitory splint? Not effective in controlling the spasticity. And I put the needle in. You can see I'm stimulating the musculocutaneous nerve. And afterwards, I pull the arm down, and here he is afterwards. Okay? Put a little bit of phenol onto the nerve, and if they have the ability beforehand, they'll still be able to pick the arm up. For the fingers, we often see the patient with a clenched fist. So with a clenched fist, if they have the ability to open the fingers, one of the ways to find out is just flex the wrist. And as you flex the wrist, the tenodesis is diminished. If they can start to open the fingers, now they have the potential to have a functional hand, or at least use the hand as a gross assist. I don't want to chemodenervate or weaken all the muscles, and it's been shown that the flexor digitorum profundus that goes to the last digit, if you just block that, they have a better chance of opening the hand, because that muscle alone, as you flex, will also flex the DIP and the PIP joint. And here she is after an injection, able to open the hand, and here's where I insert the needle in the proximal forearm for that. For some patients, the injection this is pre-injection, stroke patient, clenched fist, thumb and palm. Here it is post-injection. It's all about hygiene for many of the patients. So select your patients, and depending on what the problem is, you'll know what to do. This is a patient who came to me from a nursing home. And I see this in the nursing home often because the patients have not been treated, and they're not going to necessarily inject a toxin, which is expensive. So this patient came to me with severe pain with the hand flexed Here she is, another view. And after an injection to the ulnar nerve, look at this, but now's the worst. This is right into the muscle. No wonder she was having so much pain. So we need to be aggressive in preventing the contractions. Splints are helpful, but that's not necessarily the sole answer. You may need to chemodenervate the muscles, destroy part of the nerve going to the muscle, or block the electrical activity going to the muscle. Let's go into the lower extremity. All right, so this is a patient in her 40s who had a stroke, and let's watch her walk. This is, here we go. So, I want you to notice, first of all, she's plantar flexed with a genu recurvatum. This is very difficult to understand, at least for me it is. So if you can enlighten me, I certainly appreciate it. Number one, I always think of ground reaction force, action reaction. For every action, there's an equal and opposite reaction. You bounce a ball, comes right back up. The foot comes down over here, that means the equal and opposite reaction is vertical, and that's going to force the knee posteriorly. Make sense? So how do we prevent, for this patient who does not have ankle dorsiflexion or plantar flexion, no strength for the dorsi or plantar flexors. So for the dorsiflexors, she can't lift the ankle up, so she doesn't get a heel strike. We'll put an AFO on her, and that will give her the heel strike. Second is, she doesn't have plantar flexors, so when she's standing, the knee is going to extend, plantar flexion. So, for that, we're also going to use some sort of a device. And in this case, it's an AFO. Let's see if this alone is able to prevent the genu recurvatum. What we want is the ground reaction force to come up, but with the knee forward over here, and that will prevent that from happening. So, you know, we missed the video. How come I couldn't get it going? Look at the ground reaction force. That time she kept the knee forward. Oops. It's way behind the plantar aspect of the foot. So this needs to be treated. And if it's not, the patient's not going to be ambulatory and it's going to have multiple falls. So we put the AFO on. And I'm also going to put a heel lift in. So, look at the ground reaction force. Not quite where we want it. I'd like the knee to be further forward. But it's much better than it was before. So, Jeff, we need to work on these slides with this. So here she is with an AFO and a heel lift. And the heel lift is going to shift the weight forward. It's almost like wearing high heels. So this is about 4 months later. She has now she now has a stabilizer cane. She has her own AFO, and I put Tamarack hinges in there, which assist with dorsiflexion. And it's got a posterior stop to help prevent the genu recurvanum. Rarely, almost never, do I use a molded ankle foot orthosis because it locks the ankle in whatever position you put it in. And then the patient, they come to me, and I'm trying to get rid of that plantar flexion contracture to normalize gait. So think AFO, dorsiflexion assist, and the other thing is this is something that should be prescribed by people who are knowledgeable about gait. Oftentimes I see the family doctors prescribing it and just puts down and the orthotist fulfills the prescription. No, let's think in terms of a proper prescription, and we can do that while the patient is here. So let's see this video. And she's now independent. She doesn't need anybody walking behind her. Look at the heel strike, and the foot came up. If we don't treat that, this is what's going to happen. They get a plantar flexion contracture. This is a TBI, and after injections to the tibial nerve at the popliteal fossa, I decrease the tone for the plantar flexor muscles, and he now at least can get his foot flat on the ground. Many patients who have spasticity, as this patient does with multiple sclerosis, have hip adductor spasticity. Okay. So notice I pull one leg and the other leg follows along. That's severe. I'll call this an Ashworth 3+ to a 4 with severe hip adductor spasticity. And we have a patient right now in the hospital with this. So this patient needs to be treated. After an injection to the obturator nerve, she was able to lift the leg, and there it is. That's within about, a minute or two after a phenol injection. So, and this is important, this patient is non-ambulatory, but for this patient, narrow base of support with the ankle down and in, equinovarus, post-injection, she's able to walk with the feet straight ahead. Are stroke patients adequately treated in a rehab hospital? Well, in one study, the answer is 58% were treated for spasticity. Not particularly good. And I think that pretty soon, if some lawyers get wind of this, you know how you see, do you or a loved one take this medicine and then you had side effects? Call the law offices of. I think what we're going to see at some point is, do you or a loved one get a stroke or something that caused spasticity and contractures, and now the contractures prevent you from walking, from sitting? Call the law offices of. Any questions? Not too painful, was it? So, the question I ask you is, how do we differentiate between dystonia and spasticity? Number one, the muscles are hyperactive in both cases, correct? The EMG pattern may show continuous activity or intermittent activity. But what we do see is with spasticity, it's velocity dependent. Stretch it slowly, little EMG activity as the muscle's contracting to resist. Stretch it quickly, and you'll see a lot of EMG activity, and you won't be able to stretch the muscle out. So that's number one. Second is look at the history. What is it with a spasticity? What will that person have? They're going to have a central nervous system problem in which the corticospinal tracts are injured. With dystonia, the corticospinal tracts are intact. And in both cases, the anterior horn cells are intact. So regardless, in both cases, we really need to treat them, and oftentimes aggressively. Otherwise, you're going to wind up with contractures, whether the contractures be the neck or the limbs. And contractures then are going to make it extremely difficult for this patient to be functional, and can cause, as we saw, blisters and pain. So, how many people are going to be aggressive in treating spasticity and dystonia? All right, we're giving the lecture again tonight at 5 p.m. And I know, I will say, there's a role for exercise, for therapy, but I believe that we need to first treat with injections for the spasticity, and then the stretching. If you stretch, the anterior horn cells are still intact, so all you're going to do is stretch that muscle out, but it's not going to treat the underlying problem, and that's the thing. So now, should we use oral medicine? 2008 study at Mount Sinai in New York, where they took patients who had upper limb spasticity. They gave them tizanidine, Xanaflex. It's similar to baclofen, except it's supposed to not cause as much weakness. The tizanidine did nothing on the Ashworth scale for this upper limb spasticity. They injected them with a botulinum toxin, and that reduced the spasticity for all the muscles. So I prefer to use phenol first before a botulinum toxin for most cases, because it lasts longer, and as an inpatient, we're not encountering major costs. And then touch up with the toxins and get the people into exercise and splinting if needed. Last question? Yes? FDA approved. The toxins are FDA approved. The phenol is not FDA approved. It's been used since the 1950s. There's no company that's going to submit a study to the FDA to get phenol approved. Why? Phenol costs, with about $15 worth of phenol, that will treat about 1,500 with a toxin. So why would a company want to support a study for phenol? And the answer is they're not. So you have to rely on the literature. And recently I submitted 2 papers, one with close to 300 obturated nerve blocks with no complications, and musculocutaneous nerve with about 251, I think, and no complications. Thanks.